Hello, my name is Dr. Philip Mease. I'm the Director of Clinical Research in Rheumatology at Providence Swedish Medical Center and practice rheumatology at Seattle Rheumatology Associates. I'm honored to be here today with Christy Vath, a physician assistant who has worked with me for many years. And this is something that's being celebrated by RheumNow this week. Jack has gathered a number of us who are working with APPs together to really highlight and the way in which we work together. Christy and I today are going to be talking about a patient in our practice who has severe axial spondyloarthritis. Just a little bit about his background. He's now in his 70s, but he was born in Uganda and raised there with his family, who was from India. And the one of the things that happened when he was a teenager was the country was taken over by Idi Amin, who expelled many people that were foreign-born from the country. And so our patient was the first to immigrate and actually to Canada, and then paved the way for the rest of his family to follow him. And at first, he worked in a Greyhound bus station in the province of British Columbia. And then over the years, he gradually did a number of other things, including managing hotels, and moved to Washington State, where he is now a major entrepreneur, developing and building hotels around the state and other places as well. So quite an energetic and entrepreneurial and very smart person. But over the years, since his teenage years, he had this progressive, what was called ankylosing spondylitis at the time, and only managed with nonsteroidals. So he has developed a bamboo spine, and it was at this juncture that he came to us for ongoing care. Christy, why don't you take over as you've gotten to know him?
Okay, so he came to our office in 2010, and at the time, he had both axial and peripheral symptoms. So his Schober's was only 1 centimeter at that time. He did have a history of recurrent uveitis, and it was complicated by glaucoma in his left eye. And the imaging showed ankylosis of his SI joints and basically a bamboo spine of his lumbar spine and lower thoracic. He was HLA-B27 positive and had quite elevated SED rate of 58 and a CRP of 6.4. He, at the time, was only on anti-inflammatories, and then we started him on Humira, on the usual dose of every 2 weeks. He had continued peripheral joint symptoms and continued inflammation. And so we increased it to weekly dosing. Unfortunately, he developed psoriasis. So we ended up switching him to another TNF, golimumab, and he had a flare of his uveitis and had early wear off and persistent inflammation markers. So we went to the third TNF, Cimzia, and he still had some elevation in his inflammatory markers, but was doing quite well. One night he had got up in the middle of the night to go to the bathroom, and he fell, kind of hitting his head and his neck against the wall, and went back to bed, got up the next day, decided to go see his primary care because he was getting ready to leave to Hawaii, where he had owned a condo. And so the x-ray actually was unrevealing. no fracture seen. So he jetted off to Hawaii. And unfortunately, within a few days, started having upper extremity and lower extremity paresthesias and difficulty walking. So we said he needed to get back on a plane immediately. And when he got back, was immediately seen by ortho, found to have a complete C6 transverse fracture, which was missed on the original x-ray. And he ended up with emergent surgery and stabilization. It took quite a while to, improve. He got his ambulation returned, his strength returned. He then was resumed the Cimzia and did well, but unfortunately, he during that post-op he developed a infection at the surgical site, and it required hardware removal and IV for 6 months, and it took about a year. So he did remain on Cimzia for a bit because of his symptoms were so active. But then, as it was persisting, the infection was, we had him hold the Cimzia. Well, not too long after that, he developed diarrhea and a CT of the abdomen and a colonoscopy was consistent with Crohn's. So unfortunately, all symptoms with Cimzia, so we switched him to golimumab, and at the time he was on Entyvio from GI. Despite that, he developed new dactylitis, had recurrent enthesitis, and increased peripheral joint symptoms. So we ended up adding upadacitinib in and switched them to IV golimumab and overlapped with the Entyvio for about a month or two before it was discontinued. And he's done quite well on that. His inflammatory markers improved. His Crohn's is in remission. His fatigue improved. He's had no serious infections. And his musculoskeletal symptoms, his pain improved from like a 7 out of 10 to a 2 out of 10. So this represents a very complicated and what we'd say difficult to treat patient. So I'll let Dr. Mease take it away and see what thoughts he has about our plans of therapy.
Christy, thanks so much. And you've been involved all along the way and been a really important person for our patient to communicate with in the office if I'm not there, for example. So I really appreciate our teamwork in being able to care for him, complicated as very much so. And it also bespeaks the team that it takes to take care of such a complicated patient. Gastroenterology, orthopedics, ophthalmology, would be examples of the full team along with you and I. So he is, I just think he's a remarkable character, very resilient, and has always had an optimistic attitude despite all of these setbacks. It also illustrates all the various comorbidities and associated conditions that can occur with axial spondyloarthritis, including IBD, uveitis, the important comorbidity of the potential for vertebral fracture, and that was almost lethal for him. So I think that this is something that is a really important illustration of all that can happen with AxSpA. I should also mention to you that he happens to like to drive fast cars. And I've actually had a chance to drive with him at one point, but he's got this BMW M5 or something like that, that is all tricked out with mirrors all over the place. because he cannot turn his neck at all. And so for him to drive safely fast, he's got this tricked out car. So that's part of the joy of being a rheumatologist and physician's assistant in a rheumatology practice, being able to have a very long-term and very neat relationship with patients over time. Thanks so much for listening.
Thank you.